Hello, good afternoon, everyone. Can you see the screen? Okay, now let's start. Am I audible? Okay, so today's topic will be discussing about how to estimate the level of the serum bilirubin. So in this picture, you can see eye with yellow discoloration of the sclera. So yellow discoloration of the sclera, the condition is known as jaundice. Okay, so this is due to the increased level of bilirubin in our body. So let's discuss a brief about bilirubin metabolism, how it is formed, and different type of jaundice, and how to estimate bilirubin in serum in our lab. Okay, so let's start. So bilirubin, it is a bile pigment, right? So bilirubin is formed by the breakdown product of heme. So heme is present in RBC, in hemoglobin, and other heme protein. Most of the bilirubin, 75% of the bilirubin is formed from RBC lysis after the breakdown of hemoglobin. And the remaining 25% comes from heme protein like cytochrome, myoglobin, catalase, and peroxidase. And this is the structure showing how heme is converted into biliverdin and then to bilirubin. So metabolism of the bilirubin comprises of formation, then transportation in the plasma, then uptake by the liver and conjugation of bilirubin in the liver, and then the conjugated bilirubin is then excreted through bile. And formation that is breakdown of the RBC, it occurs in the reticuloendothelial system. This converted heme into breakdown of the heme and it converted into biliverdin, then to bilirubin. Bilirubin that is formed in the reticuloendothelial system and that is released in the circulation is unconjugated form. This unconjugated form of bilirubin is non-polar. Okay, so it has to bind with plasma protein albumin for its transportation in the circulation, right? So in the circulation, albumin and bilirubin binds together, and albumin transport unconjugated form of the bilirubin to liver. And in the liver cells, hepatocyte take off the unconjugated form of bilirubin to convert it into conjugated form with the help of glucuronide transferase. Then after conjugation, the conjugated bilirubin is then excreted through bile, and then in the bile duct, then to intestine, and in intestine it is converted into urobilinogen, and then urobilinogen further convert into urobilin and then stercobilin. Okay, so this is the diagrammatic presentation of the bilirubin metabolism. Here you can see reticuloendothelial system breakdown of RBC convert into bilirubin, and this form of bilirubin is unconjugated. In the circulation, unconjugated form of bilirubin binds to albumin, and this albumin, along with albumin, it goes to liver, where the conjugation of bilirubin takes place with the help of the enzyme UDP glucuronide transferase to convert into conjugated bilirubin. Okay. And this conjugated form of bilirubin, which is polar in nature, is excreted in bile through biliary canaliculi to bile duct, and this bile duct is open to duodenum, that is intestine, and inside the intestine, conjugated bilirubin, that is bilirubin glucuronide, converted into urobilinogen. So here, from the intestine, this urobilinogen can goes back to the liver, and this circulation is known as the enterohepatic circulation from intestine to liver. Okay, so this most of the urobilinogen goes to liver, and small amount can excrete through urine. Then this urobilinogen further convert into urobilin and stercobilin. The stercobilin makes the stool color brown. Okay, so this is the overview of bilirubin metabolism. It's important to know the difference between the conjugated and the unconjugated bilirubin. So because in different type of the jaundice, there is different increase in the level of unconjugated and conjugated form of bilirubin. Accordingly, jaundice can be divided into different types. As unconjugated bilirubin is just formed from the reticular endothelial system. It is normally present in plasma, and it binds to albumin, right? And conjugated form is present in the bile as a bile pigment. Conjugated means it is conjugated to glucuronic acid in the liver cells. And filtration through kidney. Unconjugated, as it is non-polar in nature, it can filter through the kidney. It cannot filter through the kidney. And conjugated form can filter through the kidney. If the plasma level of the conjugated bilirubin is high, then it can filter through the kidney. So the bilirubin which is present in the kidney in case of the obstructive jaundice is the conjugated bilirubin. Okay. As I have told you before, the unconjugated bilirubin is non-polar in nature, so it can cross the blood-brain barriers and it can cause brain damage. While the conjugated bilirubin cannot cross the blood-brain barriers. And Vandenberg test, which we'll be discussing later. So normal range for the bilirubin in a body. Total bilirubin normal level is 0.2 to 0.8 milligram per deciliter. And the conjugated form of the bilirubin, which is also known as direct bilirubin, ranges from 0.1 to 0.4 milligram per deciliter. and unconjugated bilirubin normal range is 0.2 to 0.7 milligram per dl. These are the normal range in our body. Now coming to the estimation. How to estimate the level of the bilirubin in serum. Different methods are there to estimate the bilirubin level, like chemical method, enzymatic method, and some other methods. In chemical methods, it consists of Vandenberg method, Malloy and Evelyn method, Januszek and the Grove method. Okay, and we'll be discussing one by one. And in your practical, this chemical method will be performed by you during your practical class. So chemical method. Basically, chemical method is based on diazo reaction. And this is introduced by Vandenberg in 1918 for the serum bilirubin. Here in this method, bilirubin which is present in the serum will react with diazotized sulfanylic acid. Okay, this diazotized sulfanylic acid is also known as Andrich reagent to produce the purple color azobilirubin. And this purple color of azobilirubin can be measured in colorimetry and spectrophotometry. So the intensity of the color, depending on the intensity of the color, levels of the bilirubin can be estimated. Here you will use diazotized sulfanic acid, and this diazotized sulfanic acid is formed by reaction of sulfanylic acid along with dilute HCl and sodium nitrite. Okay, so this diazotized sulfanylic acid will react with bilirubin to form azobilirubin, which will give the purple color. Vandenberg reaction. This is based on diazo reagent. It can be of two types: direct Vandenberg reaction and indirect Vandenberg reaction. In the direct Vandenberg reaction, diazo reagent react with conjugated bilirubin, which is water soluble in the aqueous solution. Okay, to give purple color compound azobilirubin. So direct Vandenberg reaction will give positive conjugated bilirubin. That is, direct Vandenberg reaction will detect only conjugated bilirubin. What about unconjugated bilirubin? Unconjugated bilirubin can be detected by indirect Vandenberg reaction. So the same reaction is carried out in the presence of methanol. When the reaction is carried out after addition of the methanol, then this methanol will break the intramolecular hydrogen bond which is present in unconjugated bilirubin. So this unconjugated bilirubin will convert it, the intramolecular hydrogen bond will be break down. So by this reaction, by the addition of the methanol, conjugated and unconjugated bilirubin both will react with diazo reagent to form purple colored compound. So by indirect Vandenberg reaction, both conjugated bilirubin and unconjugated bilirubin can be measured. That is, total bilirubin can be measured by indirect Vandenberg reaction, while by direct Vandenberg reaction, only conjugated bilirubin can be measured. Okay, so here methanol will act as an accelerator. This will break down the intramolecular hydrogen bonding. This is present in unconjugated bilirubin. Okay. This direct Vandenberg reaction and indirect Vandenberg reaction both are based on diazo reaction, right? So some of the variation of this diazo reaction, like Malloy's and the Evelyn method. In Malloy and Evelyn method, methanol is used as an accelerator to facilitate the reaction of unconjugated bilirubin with diazo reagent, like I have previously mentioned here. In indirectly Vandenberg reaction, methanol is used. So basically this Malloy and Evelyn method is indirect form of Vandenberg reaction. And another variation of this diazo reaction is Dendenser and the Grove method. Here, caffeine and sodium benzoate is used as an accelerator. Here, caffeine and the mixtures of caffeine and sodium benzoate will displace the unconjugated bilirubin from the binding site of albumin. So there will be the formation of hydrogen bonding between the bilirubin and caffeine. This makes bilirubin water soluble and it facilitates the reaction with diazotyl acid. So by this method also you can measure unconjugated bilirubin. So conjugated bilirubin can be measured by direct Vandenberg reaction. By direct Vandenberg reaction, only conjugated bilirubin can be measured, and by indirect Vandenberg reaction, and by using this accelerator, unconjugated form of the bilirubin can also be measured. So these are based on diazo reaction, and these are the chemical method for the estimation of the bilirubin. Now coming to enzymatic method, it is based on the oxidation of the bilirubin to biliverdin by the enzyme bilirubin oxidase. Okay, but this one, but you are going to perform chemical method during your practical class. Here bilirubin oxidase is used. And in alkaline pH and in presence of the SDS and the sodium chloride, bilirubin will be converted, oxidized to biliverdin, and biliverdin will further oxidize to purple color compound, then finally to colorless compound. Here there will be a decrease in the absorbance at 450 to 460 nanometer. Okay, because there is decrease in the color from purple to colorless compound, and this decrease in the absorbance is proportional to the concentration of the total bilirubin. And some other methods like direct spectrophotometry. By direct spectrophotometry, you can measure the total bilirubin by taking the absorbance at different wavelength, and bilirubin, different fraction of the bilirubin can also be measured by HPLC, high performance liquid chromatography. Okay, these are the different fraction of the bilirubin: alpha bilirubin, beta, gamma, and delta bilirubin. Okay, this 4 fraction can be measured by HPLC. Delta bilirubin is a fraction of the bilirubin that is covalently bound to albumin. Okay, so during the recovery phase of this jaundice, if there is presence of the yellow discoloration, even though the plasma level of the bilirubin, total bilirubin, is decreased, that is due to delta bilirubin. Okay. So now coming to how to estimate. First, you need to collect the sample. Sample can be of serum or plasma. And ideally, the morning sample is preferred in order to prevent lipidemia. And excessive hemolysis should be avoided because hemolysis of the blood will cause false decrease in the bilirubin value. And after collection of the sample, after withdrawal of the sample, this test or assay should be carried out within 2 hours of the sample collection. So these are some of the precautions while collection of the sample for estimation of serum bilirubin. So in lab, in your practical lab, we are going to use this Malloy and the Evelyn method for the estimation of the serum bilirubin. Okay, so principle is same. I have discussed it before. Like diazotisulfonilic acid, when react with bilirubin, convert into azobilirubin, which give purple color, and the intensity of the color will be measured by colorimetry. Okay, photometrically it will be measured. So both the conjugated and unconjugated bilirubin give both conjugated and the unconjugated bilirubin will give azobilirubin with diazotisulfonilic acid. Difference is in conjugated bilirubin react directly with the diazotisulfonilic acid, that is direct reaction, whereas in order to measure unconjugated bilirubin, methanol is required. Methanol is required as an accelerator to measure the unconjugated bilirubin. Okay, so by direct reaction, only conjugated bilirubin can be measured, and by indirect reaction where methanol is required, okay, it will give the total bilirubin, both conjugated and the unconjugated bilirubin. So reagent required for this practical are diazo reagent, okay, diazo blank, methanol, and bilirubin standard that is required. So diazo reagent is made freshly, okay, by using the solution A and the B. This method is a bit different from the method that is given in your book. So we are going to follow this procedure. So please note down the reagent and the method which we will be discussing here, because this is different from what is given in your practical manual, and we are going to follow this method. Okay, so reagent required is diazo reagent, and diazo reagent is freshly prepared by using the solution A and the B. A solution A consists of 1 gram of sulfonilic acid and 15 ml of concentrated HCl in water. And solution B consists of 0.5 gram of sodium nitrite in 100 ml of water. By mixing these two solutions, diazo reagent is formed. And diazo blank is concentrated HCl in water, and methanol is required for the indirect reaction, and bilirubin standard. Here the concentration of the standard is 10 milligram per deciliter, and the standard solution is formed by dissolving 10 milligram of bilirubin in about 5 ml of sodium carbonate solution. And after dissolving 10 milligram of bilirubin in 5 ml of sodium carbonate solution, volume is made up to 100 ml with plasma, human citrated plasma. So basically the concentration of the bilirubin standard is 10 milligram per deciliter. Okay, we'll provide this concentration. You don't have to perform all this dissolve and all. You will get the ready-made standard bilirubin sample. Here, this is the procedure which is different from your manual book. Okay. Here you have to take 6 test tubes. 2 test tubes for the standard, 2 test tubes for the total bilirubin, and 2 test tubes for the conjugated bilirubin. And label all the 6 test tubes with this SC total, TC means control for control, and T conjugated and T control. Okay. And in all this test tube, you have to add this given amount one by one. From top to bottom. Okay. In the standard S, you have to add 0.2 ml of the standard solution, then add distilled water, diazo reagent, and methanol. And in the standard control, you have to add 0.2 ml of the standard solution, distilled water 1.8, diazo blank. In this control, you have to add the diazo blank, not the diazo reagent. Okay, and then methanol. And for total bilirubin, that is for indirect reaction, at 0.2 ml of serum, 0.2 ml of serum, then distilled water, diazo reagent, and methanol 2.5. Similarly, in the total bilirubin control, in the control test tube, you have to add 0.2 ml of serum, then distilled water, diazo blank, and methanol. This are for the indirect reaction, indirect Vandenberg reaction, where methanol is added. And for conjugated bilirubin, in T conjugated test tube, add 0.2 ml of serum, distilled water 4.3, diazo reagent 0.5. Here methanol is not added because it is direct reaction. And conjugated bilirubin, here you have to add serum, then distilled water, and diazo blank. Okay. So after adding all this constituent in the 6 test tube, we have to mix it properly. Okay, mix the test tube properly and allow to stand in the dark for 30 minutes. You have to keep this test tube in the dark area for 30 minutes. And after 10 minutes, you have to read the ODs. You have to measure the ODs at 540 nanometer. Okay, and here in this test, for blank, you have to use distilled water as the blank. First, set the colorimetry by using distilled water as a blank 00, and after that, take the OD of the different test tube of this 6 test tube. Okay. So this is the procedure for the estimation of serum bilirubin. So after taking the ODs, you will get, after reading the absorbance, you will get the ODs of this different solution, right? For S, for standard control, for this total bilirubin test tube, and total bilirubin control test tube, total conjugated bilirubin test tube and control conjugated bilirubin test tube. Here C stands for control. So you will get six ODs value. Okay, right? So after getting this, after checking the absorbance, now you will calculate the bilirubin concentration. So for total serum bilirubin, here you will write the ODs of the E total, okay, minus total control, ODs of the total control divided by ODs of the standard minus OD of the standard control into concentration of the standard. Here concentration of the standard is 10 milligram per dl. After putting all the ODs here, you will get total serum bilirubin level. Okay. And this is indirect method by using the methanol. And for conjugated serum bilirubin, you will get the conjugated serum bilirubin by putting ODs value in this formula. OD of the test conjugated, OD of the test conjugated control by standard ODs and control standard ODs into concentration of the standard. Concentration of the standard is same, that is 10 milligram per dl. Okay. So you will get the values of total serum bilirubin and conjugated serum bilirubin. And unconjugated bilirubin will get the unconjugated bilirubin by subtracting conjugated bilirubin from the total bilirubin. So in this way, you are going to calculate total serum bilirubin, conjugated serum bilirubin and unconjugated bilirubin. Okay, so this procedure is different from what is given in your manual, and we will follow this procedure during your practical. Okay, so now coming to interpretation. You will get a bilirubin value, right? And I have already shown you the normal range of bilirubin in the normal healthy person. So normally the bilirubin level in the serum in the blood is always less than 1 milligram per deciliter. And if there is increase in the bilirubin level in the blood, yellowish discoloration of the eyes and the skin can be seen, and this and there is and when the level is increased, then it is known as hyperbilirubinemia. Okay, so more than 1 milligram per deciliter is hyperbilirubinemia, but yellowish discoloration, the term is known as the jaundice, can be detected only when the serum bilirubin level is more than 2, at 2.5 milligram per deciliter. Less than 1 is normal. More than 1 is abnormal, but jaundice, yellowish discoloration can be seen only when the bilirubin level is more than 2. Okay, so the level between 1 to 2, it's not a normal condition, it's abnormal condition. Okay, so the level between 1 to 2 milligram per dl is known as the latent jaundice or subclinical jaundice, where there is no discoloration of the skin. There is rise in the bilirubin level, but there is no discoloration, and the term is known as the subclinical jaundice or the latent jaundice. Okay. So in your practical, after getting this value, you should interpret your finding, whether it is decrease, whether it is normal level of the serum bilirubin or increase in the level of the serum bilirubin. Increased level means hyperbilirubinemia. So, clinical importance of the increase in the level of the bilirubin. Let's discuss this one. So, hyperbilirubinemia can be of unconjugated, conjugated, and the mixed hyperbilirubinemia. Can be of the three types: unconjugated type, conjugated, and both unconjugated and the conjugated variety. Let's discuss one by one. Unconjugated hyperbilirubinemia. It is also known as a retention jaundice. Okay, unconjugated form before the conjugation in the liver. Okay, so this type of the jaundice is caused due to the retention of unconjugated form of the bilirubin in the circulation. When there is increased amount of unconjugated bilirubin in the circulation, and it can cause due to hemolytic and non-hemolytic condition. Like hemolytic condition is also known as pre-hepatic jaundice. Like when there is increase in hemolysis of RBC, when there is increase in the breakdown of RBC, hemoglobin will convert it into the bilirubin, right? So there will be increase in the level of the bilirubin, that is unconjugated form. Okay. So the causes are due to when there is problem in the RBC, like abnormal shape of the RBC, like in case of the hereditary spherocytosis, RBC becomes sphere shape, okay, and there is increased breakdown of the RBC. And in different hemoglobinopathies like sickle cell anemia, right? And in case of the Z6PD deficiency, there will be increase in the breakdown of RBC. So more hemolysis, more breakdown of heme, and so more unconjugated bilirubin. And unconjugated bilirubin can also increase in case of the incompatible blood transfusion, like antigen antibody reaction during the blood transfusion. There will be a hemolysis, and in case of the malaria, when the malarial parasite Plasmodium stays inside the RBC, there will be hemolysis of the RBC. So these are the condition causes of increase in the level of unconjugated bilirubin in the blood, and this condition are included are example of the pre-hepatic jaundice. Pre-hepatic jaundice before the liver, before the conjugation takes place, right? Okay, so mostly the unconjugated bilirubin level is increased due to hemolysis, and some of the non-hemolytic cause of increase in the unconjugated bilirubin are when there is impaired in the hepatic uptake of unconjugated bilirubin. In case of the Gilbert syndrome, these are in one error of metabolism uptake. So if there is decrease in the uptake, then conjugation cannot occur, and there will be increase in the level of unconjugated bilirubin. And also when there is impaired in the enzyme glucuronide transferase, which is required for the conjugation of the bilirubin in case of Brigger-Naser syndrome and also in Gilbert syndrome. Gilbert syndrome can be of two types, like it can cause impaired in the hepatic uptake, and also there can be impaired in the glucuronide transferase. And non-hemolytic causes of increase in unconjugated bilirubin can be due to can occur in the physiological jaundice of newborn, like in case of the newborn, when there is preterm baby, in case of the newborn, the liver is not fully mature, immature liver. So immature liver cannot conjugate this conjugate this bilirubin due to the decrease in the enzyme, because the liver is immature. So in case of the physiological jaundice also, you can see there is increase in the level of the unconjugated form of the bilirubin. Okay, so these are the different causes of increase in unconjugated bilirubin. Now coming to the conjugated form, increase the level of the conjugated form. So this is also known as a regurgitation jaundice, and it is caused due to the regurgitation of the conjugated form. That is, after the conjugation of the bilirubin, the conjugated form is back into the circulation. Okay, normally it is supposed to pass to the biliary system, but it is regurgitated into the circulation. In this condition, there will be increase in the conjugated form of the bilirubin. So these are some of the causes of the increase in the conjugated form of bilirubin. So after the conjugation of the bilirubin, when there is impaired in the transport to the biliary canaliculi, in case of Dubin-Johnson syndrome and Rotter syndrome, there is impaired in the transport of conjugated form of the bilirubin to biliary canaliculi. Okay, so there will be increase in the level of this conjugated form of bilirubin in the blood. And when there is impaired in the flow of the bile in the bile capillaries, okay, intrahepatic cholestasis, when there is impaired in the flow. Impaired in the flow can be of two types. It can occur intrahepatic and extrahepatic. Intrahepatic is within the liver. The bile canaliculi or bile capillaries is present in the liver. So when there is impaired in the flow of the bile inside the liver, that is in the bile canaliculi, okay, there will be increase in the level of conjugated form of bilirubin, and it can occur in case of the primary biliary cirrhosis and carcinoma, intrahepatic carcinoma. In intrahepatic carcinoma, there will be increase in this conjugated form of bilirubin. Now coming to cholestasis due to extrahepatic cause. The cholestasis in extrahepatic cause, it is also known as a post-hepatic jaundice or obstructive jaundice, right? Obstructive jaundice, when there is obstruction in the flow of bile extrahepatically, and it can be due to gallstone in the bile duct. If gallstone is present in the bile duct, this will impair the flow of the bile. And if there is any carcinoma of the bile duct, atresia of the bile duct, abscess of the bile duct, stenosis of the bile duct, there will be hampered in the flow of the bile. The there will increase in conjugated form, and most commonly is carcinoma of the head of the pancreas, which will press the biliary duct. This carcinoma of the head of the pancreas will be, there will be obstruction in the flow. Okay, so this comes under the obstructive jaundice, post-hepatic jaundice. Okay, and in post-hepatic jaundice and in these two conditions, there will be increase in the level of the conjugated form. Okay, now coming to the mixed hyperbilirubinemia, when there is increase of both conjugated and the unconjugated form. Basically, it is seen when there is necrosis of the liver cells. When there is necrosis of the liver cells, there will be both conjugated and the unconjugated form will be increased. Like in case of the viral hepatitis, and due to some drugs like cytotoxic drug, isoniazid and tetracycline, and alcohol intake, these are some of the conditions which will cause the increase in the level of both conjugated and the unconjugated bilirubin. Okay. So in your practical, you will be performing this method, Malloy and Evelyn method. This is basically a direct Vandenberg reaction and indirect Vandenberg reaction by using the methanol. Okay. And this one you have to note it down because this is different from what is given in your manual. And in every practical, you have to know the interpretation, how to interpret your finding, whether it is in the normal level or if it is increased, then what can be the causes of the increase in the level of any parameter. Okay. So these are different type of hyperbilirubinemia. Okay, depending on the level of increase in conjugated, unconjugated, or mixed, and different causes of conjugated form of the unconjugated form and conjugated form of bilirubin and mixed form. All these things you have to know for your Viva. I think that's it. Thank you. Yeah.